Okay, so I'm going to start. And actually, I'll look at that time up there. Alrighty, so I'm talking about nurse coaching in the inpatient rehabilitation setting. I'm going to read my notes a bit because otherwise I tend to converse on and we'll be taking double the time. So I'm just going to stick to the script today, which I think you'll appreciate. This is, are my slides there? Awesome. Alrighty, so this is a joint research project that I'm doing with two colleagues, and so I'm going to work this out. Last one? There we go, thank you. So Caroline Stretton is also from Auckland, and she is a lecturer at AUT University and teaches health coaching. And Julie Pryor works in the Director of Research in a very large rehabilitation unit in Sydney. My role title is Director of Nursing, and I work in a multi-centre company that specialises in brain injury rehabilitation. And I'm based in Auckland, although our units are all around the North Island. Oh, I'll get it together. All right. So to give you some context to the project briefly, a key focus of rehabilitation is to enable patients to develop self-management skills. Health coaching and promoting self-management are embedded in our rehabilitation nurse competencies, but not well defined or collectively understood. And so we wondered whether health coaching principles could be applied to nurses' practice and the way that we work as nurses, particularly in an inpatient traumatic brain injury or TBI rehabilitation context. So this project came from my doctoral research, which indicated that nurses seldom documented their coaching or teaching activities in their clinical record or in their documentation. So the three of us had conversations about existing literature around health coaching. And when we reviewed it, we realised there'd be challenges in translating it to the particularly brain injury, but inpatient rehabilitation setting. So before moving further, I just wanted to define health coaching just to make sure that we're all on the same page. There's actually a number of different definitions out there. So for us, health coaching prioritizes a collaborative therapeutic relationship. It enables the use of a variety of interpersonal techniques so that the patient can make changes to their health, their function, or their general well-being. So in a review of the literature, we found that health coaching drew mainly from a community health promotion context, where the coaches worked one-to-one with their patients. Also, it was used in patients who had intact cognition, and they could participate fully in their health choices, which is not always the case with our patients post-traumatic brain injury. So we identified two main frameworks that identified health coaching techniques. Between them, identified 114 different techniques. And so we were interested in the absence of the nurse's voice in the health coaching literature. No one had actually asked rehabilitation nurses about how they apply these techniques in their everyday. And nurses are traditionally, I think, known for what they do, not how they do it. So our project was very much focused on the gap of the nursing voice rather than patient experience or outcomes at this stage. So this is an overview of our project, and I'm going to talk about the phases in more detail. So there's a couple of phases, so I'm going to go through them. So as I said, I work in brain injury rehabilitation, and we chose this area of rehab as our focus for the research. We were particularly interested in the collective practice of nursing and chose two units where we could explore the way things worked in each unit from a nurse coaching perspective. So here are the two units where the research was set in phase 1, and we are also starting with these units in phase 2. So Royal Rehab in Sydney in Australia is on your left. Yes, and where I work in Auckland, ABI Rehabilitation is on your right, and both units specialise in traumatic brain injury. So as a team, we talked a lot about teaching, coaching and self-management and the challenges that our patients had in learning and relearning following a traumatic brain injury, and consequently how nurses can support them in this. We recognise that some of the existing resources from the coaching literature might be transferable, but we were unclear how well it would fit with our patients, with the setting, and actually with the way that nurses work in the inpatient setting. So where's the research team developed the topic of inquiry, and the participants then shared their experience of that phenomena. So that was the nurses. This approach supported our intention to remain contextual in asking the nurses what works well for you now, and how are you interacting with our patient group. So our research data considered the social structures, the culture and agency. So the routines and mores of the organisation, the beliefs and experiences nurses hold individually and as a group, and how they choose to interact with their patients. We were cognizant that nursing in specialised brain injury rehabilitation units is contextually unique from other nursing and coaching settings. So we interviewed 10 participants, 10 nurses, 5 from each site, and we asked them to give us an example of a time when they supported a patient to self-care or to self-manage their health or well-being, what was said, what the nurses did and why. So the interview data was then mapped onto the frameworks of health coaching techniques, and we analysed that. We employed an abductive analysis method. Initially, our analysis was based on the template of the health coaching frameworks, but over the many following discussions, we recognised the patterns and contextual differences in the data. So this is just an example of the mapping that we did. The nurse participants described a range between 9 and 36 different techniques each, and it averaged out about 18 coaching techniques per transcript from the couple of stories that they told or the scenarios that they gave us. We explored if and how nurses use these techniques, in what ways and for whom that they worked well. Identifications of these patterns of events through their narratives helped us identify tendencies within this context. So the patients, their stages of injury, their health literacy now and in the past, or actually that includes what they could recall of the health choices or the health decisions that they may have made before their injury. Also, the rehabilitation environment and the attributes of the nurse themselves were amongst the factors that we considered in our theory and our theorising. Our analysis wasn't based on a frequency approach, but rather what health coaching techniques seem to be most useful and appropriate in this context by analysing the content of the examples given. So our second stage of analysis, following discussion with the team, was to interpret our coded data with a view to informing clinical practice. And we grouped the techniques in relation to the target of each technique. So to do this in relation to clinical daily practice, the 4 areas that nurses could conceptualise as target areas to influence, namely what the patient does, what the patient thinks, how the material or physical environment is set up or adjusted to enable self-care, and the social and attitudinal environment surrounding the patient, which is made up of interprofessional interactions between the nursing staff, other healthcare professionals and their family, and how each group individually or collectively interacts with the patients. So using these 4 areas as a framework, we recoded the techniques jointly to determine whether this categorisation aligned with the data, and we identified 20 nurse coaching techniques across the 4 target areas. So our initial technique definitions were shared back with the focus group to gain their perspectives and encourage participation with the concepts with a view that they might champion some future implementation. So phase 2, this is our current research phase, having just got our second research approval, both from Auckland and Sydney, which is a whole another topic in itself, so I can tell you. So we developed a practice development program, which will soon roll out. Alongside of the rollout of the education, we'll use surveys and focus groups to ask questions about the program, and that's user experience, delivery of the content, and also ask the nurses their perspectives about the content usefulness and their confidence in using the nurse coaching techniques in everyday practice. So this will enable us to identify mechanisms and understand the barriers or enablers that may impact successful adoption. I guess those structural and cultural factors. and test our theory of nurse coaching within the inpatient setting. So implementation of the practice development is via a Google Drive site, which the nurses will have access to, and it contains videos, PowerPoints, activity sheets and quizzes, and then the research survey links. So there are 4 modules taking approximately 1 hour to complete. And we set this up so that they can learn the content in a group with a facility champion, or they can actually view it independently. And that flexibility is quite vital with nurses, because the nurses in the front row here will know that nurses work shifts, and we can't just get everyone off floor to education together, because, you know, when someone's on morning, someone else is on night duty. So it doesn't really work that way. So within our implementation, we have 2 rollout periods, the initial 2 research units first, and then rehabilitation units that see patients who do not have traumatic brain injury, so that there we can test if the NCTs are applicable also outside of the TBI population. And in all, the research will be conducted in 5 inpatient rehabilitation units located in New Zealand and Australia. The other one in New Zealand is a general and older person's health unit, and the other 2 in Australia are spinal injury and a private rehabilitation. So this is just a schema so that you can see the evaluation time points. The surveys are done post-module, and then 1 survey 1 month post-completion of all the modules. And then we're going to have 2 focus groups, one at 3 months post-rollout and one at 9 months post-rollout. So that's for the first 2 units, and then we'll start with the second implementation and do the same thing, but at different time points. So theorising is being done predominantly by us as the research team, although we do have an advisory group from the sites who have been integral in providing feedback all the way along this project. The project, particularly in phase 1, required some theory building, developing new ways of understanding the structural and cultural context for nurses in these settings, and then now theory testing, exploring or explaining nurses' utilisation of the nurse coaching techniques, principles and practices, what works well within the context of inpatient rehabilitation. So seeking further explanation of what, how and why these patients align with the way that nurses interact, these principles align with the way that nurses interact with the patient group in our setting. We found Archer's morphogenetic model useful as a framework for implementation, understanding the pre-existing structures and culture, and then working to understanding and allowing for the factors that enhance or constrain change. And also we found Archer's notion of primary and corporate agency resonated with us in this project. We're particularly interested in developing a shared language and what then occurs when all nurses are articulating what they're doing in a similar way. So I'm sure you're familiar with this concept, but I've just got some quotes up here, but I'll focus on what they've meant within our research project. To define it just quickly though, Archer defines agents as collectives sharing the same life chances through having common relations to a set of structural resources. She distinguishes between 2 types of agency through 2 dimensions, the primary agents and the corporate. So primary agents are uncoordinated in action and unstated in aim. I've highlighted part of her description of corporate agents, groups who are aware of what they want and can articulate it. And we were thinking about the collective articulation that we are going for, right? So of what nurses were doing. So this was quite useful for us. She also says that corporate agents can engage in concerted action. And this has been a key part of this project we think it's what might be missing. Nurses work differently to other health professionals because they're rostered. They take over care from one to the other over a 24-hour period. And no other clinician works in this way. And so the communication for us as nurses is vital, but there's actually limited shared language related to nurse coaching. And so articulating the techniques that went well so that they can be duplicated or added to for the next person, the next nurse on the next shift, or what didn't go so well, right, is really important in terms of our communication between each other. Nurses work in a collective way, we know that, but in our facilities, it appears that they do so with as primary agents in relationship to their coaching practices. They are uncoordinated in their action and unstated in their aims. So we think there's potential to move nurses to being corporate agents through shared language, collective vision and understandings. What will this mean? This is the bit that's of interest to us in this project. So we are virtually, myself and my colleagues, hopefully we've outlined our realist principles and how they've underpinned this research project. Understanding if the project is useful for who, why, or why not. We think it'll also be useful to consider that shared language and ask questions about what components are important in change. Our multi-site rollout will assist with understanding the structural and cultural factors between the different inpatient units. We sought to understand what coaching looks like from a rehabilitation nurse perspective, because nurses within rehabilitation facilities have been denied the chance to be included. With research to date, their voices are not visible. And coaching principles and practices have inconsistently then been applied to the work that we engage in. So as we have condensed to get this presentation into this time frame, I've only presented a section of the program. This research has to date been going for a couple of years, but we've also articulated patient factors that are important and nurse attributes, which sit alongside the techniques that we've articulated here. So the setting and the personal factors add complexity to this intervention. But in summary, we're hopeful that articulation of nurse coaching techniques will assist nurses to establish a shared language and realisation that they can work collectively, building on the work of their colleagues to assist their patients to self-care. Of course, we'll consider alternate factors, causal mechanisms that are present and necessary, or mechanisms that are impacting adoption of the program. The hope is that building nurse coaching theory will enhance teamwork and ultimately more effective rehabilitation for our patient group. These are just the references from this PowerPoint. And forget this because we're not doing questions. You bring up Ruth's presentation. I'll let you introduce yourself, but I will, when you bring up his presentation, and then I can, oh no, sorry, it's Alicia, isn't it? Alicia, are you online? I see your name, are you there?
Yes, I'm here, So I turn on the camera. Yes. Hi. So I have
Yeah, are you okay to share your presentation, your side?
Yes, sure. Is it 20 minutes, is that right? Is that correct?
Yeah, 20 minutes. So since you're online, I will give you a holler when it's, I will let you know when it is 2 minutes, so that you've got 2 minutes to go. I'll let you know then. I will verbally say it so that you know.
Okay, so in 2 minutes I will start. Okay.
No, you start now, and 2 minutes, sorry, 18 minutes. I'll just let you know that
sorry,
it's 2 minutes to go, just so that you've got some timekeeping. Is that all right?
Okay, perfect.
Sorry for being unclear. You may start whenever you suits you.
Yes. Did you see the screen?
Yeah, we can see the screen. It's perfect.
Yeah, perfect. Thank you. Really, I'm very happy to share this piece of work related to my PhD thesis. So I'm Alessia Camponovo. I'm a nurse as a background, and I'm involved at the School of Health Science in Switzerland, but also at the University College Dublin in Ireland. So the title of the presentation here is Interprofessional Collaboration among Healthcare Workers in the context, of hospital team meetings. So for a quick summary, I will present to you the presentation, which contains 6 main points. First, the context, which I will present you the 2 main concepts of the thesis. Then the rationale, the research questions related to critical realism, the scoping review, and the discussion and the references. So first, let's dive into it. So I want to start with quick major public health challenges, facts, and numbers. So we have an increased prevalence of non-communicable disease, such as cancer, for example. Cancer is one of the 4 main categories of NCDs. And importantly, NCDs can occur at every category of age, whether it's middle or low income country, but it's mostly associated with older people. And besides that, we also face a demographic shift, that leads to increase the growing population of older people and consequently individuals with chronic condition. For example, we have a prediction that by 2040, the growing number of individuals with chronic conditions will require palliative care. We also face another global phenomenon, which is the workforce shortage. An estimated 4.1 million of workforce shortage among the healthcare workers is expected by 2030. And there's 3 main reasons for that global phenomenon. First one, COVID-19, which leads to mental and physical strains. The second is a lack of support and forecasting, And the third, a discrepancy between the supply and demand. So as a consequences, in European parliaments, one of the highest priority is to do the retention strategies. So this figure here illustrates the unbalanced supply and demand and the overall burden over the healthcare system. So on your left, you have the increased prevalence of NCDs, the demographic shift, but also the increased number of needs and expectation from patients and families. And on the right, you have the supply, which is represented by the healthcare workforce shortage. So one of the solutions will be to foster, to support a work environment, to increase job satisfaction, for example, and to provide greater stability among healthcare team. So what's the strategy? What's the response to global policy? Global policy advocates, one of the response would be to advocate to interprofessional collaboration. So interprofessional collaboration is defined by the process by which social and health professional groups work together to impact care positively. There's a lot of benefits regarding IPC. For example, it's key to enhancing collaborative practice, but also it's related to positive outcomes, significant positive outcomes, that, for example, it boosts job satisfaction. It's also related to team effectiveness, overall outcome related, but also it's the gold standard to address complex care. For example, effective collaboration is influenced by one of the most strongest predictor of team effectiveness, which is psychological safety. And psychological safety overall is the shared belief that interpersonal risks are the same consequences. However, in the literature, there is a lot of threats to effective collaboration. For example, we have communication issues, we have different professional stereotypes, we have diverse expertise that could create conflicts, we have poor conflict resolution, stereotypes, power dynamics, hierarchy, statute, and competitions. So overall, all these factors can shape the dynamic of collaboration. And it could also affect the overall team decision-making process and ultimately patient-related outcomes. So another main concept that I have on the thesis is team decision-making process. And it involves gathering, processing, integrating, and communicating information in support of arriving at a task-relevant decision. So the literature revealed that there's many factors influencing this process: tension, gender imbalance, case complexity, logistical complexity also, time pressure, workload, or team size. So it is really important to understand these contextual factors and also these organizational factors. So what's the point? we know now that common understanding among scholars is that recognize that IPC has a lot of benefits, and it also the better approach to address complex care. However, there still a gap remain. We don't understand actually what's the dynamic of collaboration, how does it exist, and what are the mechanisms that are underlying this process. And also regarding team decision-making meeting, we don't know how, under what condition is it effective. And as a consequences, ineffective collaboration that could lead to impact team effectiveness outcome, but also could provide high turnover among healthcare workers. So the research question and the link with critical realism, I will just add for the research question, is how does the literature describe team interaction mechanism in hospital meetings? I have three other objectives that are underlying this research question to find the key enablers and barriers to IPC, but also what are the communication strategy that healthcare professionals used to overcome all these barriers. And also the description of the processes as the mechanism among healthcare team. So I choose the critical realism, I choose the critical realism inquiry because I deeply believe, I deeply believe that critical realism offers this typical way of regarding the world as, oh, so sorry for the, I will do like this. So I choose critical realism because I deeply believe that it allows us to see interprofessional collaboration concept as mainly emerge by the hidden mechanism that we could see, for example, through power dynamics or professional stereotypes or hierarchy, really the backgrounds in the medical field, which is rooted in the hierarchy and status, for example. And as critical realism is the reconciliation of the positivism and post-structuralism, it's really allow us to see that the reality is not the reality that we see. Like, for example, in the interprofessional collaboration, we see the team meeting interaction, but the thing that we don't see is all this hidden mechanism that are, for example, power dynamics. So I will maybe discuss it later, but I will have some link within the data that I have for the scoping review. So I will just present it now. Okay, so the overall thesis objective are threefold, but I will focus on the objective of the scoping review now because I have some preliminary result that I want to present you today. So I follow the ORCSY and O'Malley framework, which involve 5 main stages. I use Covidence as a software, and I include all the empirical study in all languages that includes that really describe the interaction process, the pattern communication, all the strategy used by healthcare workers in the context of interprofessional collaboration, and the context, of course, in the hospital setting. And at the very end, we include 17 studies. So the most teams that are studied are found in the context of palliative, cancer, and elderly care team. And the majority of the study are undertaken in the UK. Also, 16 out of 17 studies are qualitative design. So I put the results of this, I put the results in 3 different levels, the individual level, the team level, and the organizational level. So To sum up, in the individual level, we have a lot of description of what kind of tool or linguistic device healthcare professionals have or used during team decision-making meeting. For example, they use a strategic question. So questioning is used as a tool to really navigate regarding the different gray zone regarding the expertise, but also the different roles of the professionals. So it's really try to have the humility to ask question on the other professional, to not say that the professional itself have the solution, but it's more to use the discussion as a team, as a whole team. There is also a description of silent bargaining regarding the professional roles, and tensions are often expressed in silence. At the team level, we have also, for example, chairing the meeting, which is very important, who distributed the voice to junior staff. And we have also the description of unequal participation among the team decision making. And at the organizational level, we have, for example, the architecture of the meeting. For example, how many times does the hospital allow the team to discuss? In which location? And yeah, really the architecture, but also the influence of policies. What is the philosophy of the hospital regarding interprofessional collaboration? Or yeah, really the influence of policies. And for example, the social worker, social domain, authors say that is being colonialized with other dominant healthcare professional. So this is, I put also this in the organizational level influence. And yeah, I will say as a discussion, you have on your left a figure. I try to illustrate the interprofessional collaboration through this figure within the structure and agency. So it's kind of a structure is the hidden mechanism, and the agency are the individual professional. And it's really to try to understand all this power influence that influence the overall process that can occur. And critical realism is there is a advocate for real world independent of our knowledge. And I just put some phrases that I heard on the 2 days so far, that reality is dynamic and connected. For example, here, the significant factors shape the dynamic of interprofessional collaboration, but also social emancipatory. Regarding here the power dynamics, it's really to allow the healthcare professional to raise the voice during those meetings to advocate for the patients. And I really love also this phrase epistemic humility regarding the critical realism, because it really allow us to have this back and forth process regarding the reality we observe. What's really the deep and rooted mechanism that allow us to observe what we observe. So overall, the application of this PhD is to acknowledge our complex social world, but also to build a live contextual model and apply it regarding the participatory approach. And I just put some limitation, time constraints. I will use mixed method embedded qualitative quantitative design through the lens of critical realism, and also the complexity of mode of reasoning, for example, regarding explanatory theory. And I will just finish with that phrase. We need to understand, otherwise the pattern will be reproduced infinitely. Thank you.
Thanks, Alicia. That was great. You easily made time. Thank you. Can I introduce our next speaker, Reese Mantell? Reece is going to talk about a critical realist analysis of digital health screening for older people in prison.
Thank you, Angela, and thank you everybody for still being here. So I'm Reece Mantell, a PhD candidate at the University of New South Wales in Sydney and part of the Justice Health Research Program there. So in this presentation today, as Angela alluded to, I'm going to discuss a recent project we just completed and published. A critical realist analysis of digital health screening for older people in prison. And that's part of a broader project called the ESCAPE project, pun intended, which is really about understanding, developing and testing digital health screening and assessment tools for older people in Australian prisons in particular. So I just want to start by briefly touching on what I'd call sort of the three big background factors that I guess really represent the why of this work. So approximately 1 in 5 people in Australian prisons are now 50 years or older. The prison population is rapidly aging. The growth of this cohort greatly outweighs the growth rates observed in the overall Australian community. So, for example, between 2009 and 2019, the number of people in prisons aged 50 plus grew by 81%, those 65 plus by 142%, which are significant numbers. Older people in prison report worse physical, mental, and cognitive health than their community counterparts, as well as younger people in prison. There's often complex multimorbidity in this group, including age-related concerns, so cognitive impairment like dementia and mobility issues. For example, 85 to 96% of people, a recent study just reported, recent study reported that 85 to 96% of people, older people in prison, experience significant health issues, including heart disease, diabetes, and hypertension. So, I mean, despite this growing cohort with a high and complex level of health need, there really is a lack of capacity in the system to respond to their needs. And as a result, there remains a significant number of conditions that go undetected, underdiagnosed, and therefore untreated. And I guess this has a large range of very negative effects. I won't go into too many of them now, but I mean, health complications, difficulty with plea bargaining, for instance, in the case of cognitive impairment, victimization and coercion is a big factor as well. Thank you. So I guess this really builds the case for proactive health screening. So what I'll say first about this is I think knowledge is power. And although I think that phrase might be a double-edged sword for many people at this conference focused on power dynamics, I think it's still true, at least in health systems most of the time, that the more you know, the more you can help people. And currently in Australia, we don't know much in this context. So screening in prison is limited and very reactive. So we primarily screen for STIs, suicide risk, medication, and allergies. That's pretty much it. So I guess this is not enough. A broader and more holistic approach is needed to detect a broad range of issues, especially for older people who often suffer in silence. So preventative-based digital screening seems like a good solution, at least in theory. Oh, sorry, no. And no, back, but yeah, thank you. So why digital? Well, digital solutions for health basically offer scalable, consistent, cost-effective ways to detect and address these age-related issues. We're seeing more and more in Australian prisons, but the bottom line is they're attractive in resource-poor settings because they're cheaper than traditional screening measures. So in community, we're seeing digital screening programs are becoming more and more powerful ways to assess broader health and social needs. So things like loneliness, frailty, sleep, trauma histories, rather than simply reacting to disease symptoms. Of course, this isn't to suggest we stop trying to screen for serious disease, but disease screening should be done within a broader, more proactive and strengths-based approach to preventative healthcare improvement. I guess the key concept here is prevention and early intervention. So detecting problems before they become real problems isn't only good for the individual, but it's incredibly cost effective. So there's a persuasive argument there as well. And this is especially important for older cohorts. So they traditionally have more complex health and age-related concerns, especially in prison. And these start small and they worsen over time. So these often remain undetected until it's too late. So I look at things like depression, frailty, and dementia as big sort of examples for this. Basically, at least in theory, proactive digital screening is an opportunity for the justice health system to move beyond reactivity and towards more proactive initiatives that grow healthy prisons. Thank you. But, and this is a big but, although screening looks like a good option, the reality is that justice health is messy. The system is very complicated. So the main objective of this study was to sort of take a step back, and we know we've got this exciting potential solution. But before trying to implement this solution or service, ensuring that we really unpack the social, cultural, psychological, organizational factors that might reduce the success of additional screening. Is it me now doing it? Oh, damn. Okay. So sorry for doing it at you. So the research question essentially for this isolated paper, which has been published, what are the mechanisms that impact adoption of digital health screening tools for older people in Australian prisons? So it's a qualitative analysis where we collected data through focus groups in prisons across New South Wales, the state in Australia. Participants included a diverse sample of older people in prison, as well as nurses and psychologists working in justice, health and correctional settings. So from the start, the study was really very much focused on applying an explanatory model. So trying to, I guess, explain, not merely describe. And that was obviously embedded by a critical realist philosophy of science. Okay, so I think recent discussions in some critical realist circles have argued for a simplified explanation of some key critical realist principles to support broader access and engagement with the core concepts. I think in particular with the empirical, actual, and the real, which seems to confuse many people right at the start and I guess dissuades them from engaging in critical realism, I suppose. So with that in mind, I followed some recent framing from the likes of people like Tom Fryer by focusing on Bhaskars's three intersecting elements of reality. So experiences, people's perceptions of things, events, the things, whether they're perceived by people or not, and generative mechanisms, the causes of events. And doing this while sort of ignoring domains of reality, which I know are often described in conjunction with these elements for very good reasons. So the paper's only just been published, so I can't say if this will facilitate more engagement, but my focus was to try and keep things as simple as possible. I guess, well, also myself engaging deeply with the concept. So example, I was thinking about real tendencies in the real and these being actualized or not when considering mechanisms, but keeping this off the paper wherever possible. So key analytical steps. The study uses Dänemark's explanatory stages of a critical realist model, and I just apply these stages as analytical steps, essentially, as part of an isolated qualitative coding process, which I think actually worked very well. And by adhering to these 5 stages, which I won't go through in detail now, but I think it really helps, understand people's experiences of recontextualizing these observations based on previous knowledge, theory, abductive inference, hypothesizing what mechanisms were producing the events in question, and then investigating the interplay of the mechanisms in question. So what we've come up with are two overarching themes. I think theme isn't quite right here, but I'm going to begrudgingly continue to use it until I have a better concept. If anyone has any ideas, let me know. But so basically it's constraint and conflict. So constraint is focusing on structural barriers towards the adoption of proactive digital health screening, and conflict, which is more so focused on individual barriers to help seeking for older people in prison. This is a quick overview of just the description of events here. So the system is already at capacity and lacks health resources even before we consider the additional demand created by screening. To complicate matters, service priorities of different groups are not always aligned. So take, for example, corrections officers focusing on minimizing risk, justice health nurses focusing on treating their patients. So this sort of is what we often call the care versus custody dichotomy in corrections and justice health, which causes a lot of problems. And I guess this often leads to limited resource availability, inevitably going to reactive, urgent, and safety needs instead of anything proactive. And I guess because of these two factors, the system capacity and service priorities, we often find that there's an understandable reluctance to change, such as to do more screening if it adds more work without adding more resources. Seems fair, but screening is welcomed by staff if it saves time. So that efficiency element is there. But what we're interested in is what's causing these events. And after doing a lot of work and analysis, which I won't go into too much detail on here, basically the claim we've come up with and proposed is that one probable cause, at least, is that the predominating cultural attitudes about the objectives of prison just do not align with the goals of health promotion. So this makes it challenging politically to allocate funding to preventative health in prison, independent of aligning with, I guess, what the goals are of prison. So retribution, incapacitation, deterrence, and rehabilitation. And rehabilitation is a complex word in prison. So what that sort of ends up being is the reality is that the prison health system is more constrained than community-based health systems most of the time, and therefore less likely to receive additional government funding for health promotion, even when the need is clearly identified. Why? Well, again, the political difficulty of allocating primary health resources to prison when funding could go elsewhere, either to other, I guess, prison services which align to these goals, so safety, infrastructure, reducing recidivism, or to more politically attractive initiatives outside the prison system, which most initiatives are. The result, people who work and live in prison don't expect changes because the current system aligns with political priorities which reflect predominant public attitudes about the role of prison. So I guess to be a bit provocative then, this analysis, well, based on this analysis, the current justice health system is commensurate with its objectives, as well as predominating public expectations about the system. In a way, this, I would argue, is sort of a classic example of morphostasis. And I guess in other words, the system is working how it was designed, which is really important to acknowledge when considering how to advocate for system change and improve outcomes. So on to conflict. So there's two sub-themes I want to talk about. Sub-themes. The predominant social norms in prison. So reduce the likelihood of help seeking. So essentially there's a lot of individual pressure to avoid being vulnerable or showing weakness. This can often manifest as a lack of openness in health seeking, particularly for mental and cognitive health issues. Inevitably a lack of openness will, negatively impact the success of a health screening measure. Traumatic past and current life experience are also going to reduce the likelihood of help seeking. So that's this complex backgrounds on the right. I think this probably won't surprise anyone, but there's an incredible amount of trauma in prison. And I just want to talk about the trauma factor for a minute and drill down on this a bit. So I argue sorry, I should just say what's causing these events. And I'm not going to talk too much about the social norms. I'm going to talk about the trauma here. And I argue at one level, or I guess at one strata, trauma underpins much of the cumulative past and current life adversities experienced by many older people in prison. Or if we don't want to say underpins, maybe embodies it. So one common consequence of trauma is a lack of trust, particularly in authority figures and institutions. So research shows that trauma history is associated with lower social support and increased feelings of hopelessness, especially among incarcerated men. In the context of digital health screening, then, this has the potential to be extremely problematic. So traumatized people often avoid disclosing their trauma history and related health issues due to shame, stigma, fear of negative consequences. This can compromise health data collection at best and re-traumatize people at worst. So while digital screening offers privacy and a lot of benefits, which I spoke about at the start, there's limited evidence that traumatized people will reveal sensitive information digitally if they weren't sort of open to doing that face-to-face. So there's another thing I should probably mention here is that the impersonal nature of digital collection also lacks the safety and support typically embedded in clinical disclosures, so potentially exacerbating shame, distress, and anger, which isn't often spoken about. So essentially, if we look at trauma as an important causal mechanism here, you start to get a more holistic and nuanced picture of how to intervene or where, possibly. And this, I would argue, just isn't really possible without a critical realist ontology and approach to causality. Okay, so this is a lot, but it's kind of bringing everything together and shows how certain mechanisms can interact to cause certain events. So this comes directly from, I guess, the section on retrodiction in the paper. So for example, we can see how public attitudes about people in prison could reinforce the social norms and identities in prison. We can also see how the need to avoid being open and vulnerable could negatively interact with someone's traumatic past, making vulnerability very much less likely, and further impacting openness to proactive help seeking, and therefore limiting the success of holistic screening. Overall, we can also see how the constraint at structural level and conflict at an individual level can really produce important barriers that might impede the success of screening. So having a deeper understanding of these can guide better next steps when developing and implementing digital health screening for older people in prison. So I think I just want to quickly say here as well that I think this type of critical realist analysis can be so valuable because basically I do a lot of applied work, and I think reporting findings in this way is very dense, but can also be a useful tool to support policymakers, health service providers, and the people implementing technologies. Because it's not about saying you have all the answers, which we never would say we do, but it's also not about simplifying the answers or offering generic, unhelpful solutions. It's about empowering people in the system by handing over a deeper analysis of specific contexts, problems, and mechanisms. It's not always possible, but I really think that this is what leads to successful interventions, good advocacy, and sustainable change, especially in quite chaotic spaces and use cases such as digital screening in prison. So just to finish, I guess my takeaways and 3 hard lessons for the digital health innovation in prison. And I know I'm like quite negative in in this presentation, and I think this is one part of my PhD, and I try and be positive in other parts. So it's not always this negative, but I think it's important to understand these barriers deeply. So I think I'm just going to go through 3 of these challenges now. So the first is the settings fallacy. So often the routine, repetitive, and structured environment of prison is seen as a potentially transformative environment to deliver effective preventative health services. This really underpins the Healthy Prisons movement, which I haven't spoken about too much, but it's gotten a lot more momentum in the last few decades, but I would argue that without systemic change, the current environment, at least in Australia, remains like fundamentally incompatible with health promotion goals. So the second point, you need compelling health data to justify resources, but you need resources to collect proactive health data. So this is the evidence paradox for me. So this problem gets worse when you're working with politically unpopular groups as well. This came up a lot in our research and needs to be considered further when thinking about equitable resource allocation, because it's not really discussed very much. Finally, the implementation gap. So policies and interventions built for ideal conditions collapse under real-world constraints and conflicts, particularly when tech adoption is involved, I've found. So understanding the context and underlying change factors is foundational to success. Having a better understanding of these is essential so we can design and implement preventative digital health tools that have a chance of succeeding in prison and creating lasting change. Thank you.
Therese? Maybe, how does that turn on? We might just take some questions for any of the three. Anyone online want to kick off? Anyone in the room? Yeah.
It's actually kind of a question for Angela, but I'll start by making a comment about Reese's presentation. I really appreciated how you tracked through what implications or payoffs a critical realist approach to the study has, both in the, I guess, the theoretical part of the research, but also in the potential application of the research. And I think that was in yours as well, Angela, but maybe a little bit more implicit. And I'm wondering if you'd like to speak to what critical realism has given to the process of doing the research, but also acknowledging that you're also in a very applied setting in terms of the objectives of what you want to achieve. Just that kind of brief would be great.
Thank you. It's hard, isn't it, when you've been in it for a while, but I just think the like exploring and developing the explanation about what's there, just understanding the different layers. I mean, ours was basically started off as an implementation, and what we recognised was very early on, because of the realist way we did it, that actually what was sitting there we didn't want to implement, because we got a range of information from different people, and we had to then develop theory ourselves about, you know, how does this work, and it doesn't work for everyone, and we don't want to leave people behind. So we don't want to just kind of generalize that here's a, you know, some health coaching techniques, just go and use them, just go and do a little bit better, you know, because in our context, for people with brain injury, it's not the same as people in the community that are living their lives and making choices. So we did have to kind of sit and really work contextually and say, you know, what works with our population and what doesn't work with our population. And then our other population is nurses in a setting that's quite different from the people that were applying the techniques. So I think it was just that layering that enabled us to really look more deeply and think more deeply about the, you know, that structures, culture, agency, approach of where all the layers were. So I think it was, yeah, I mean, I take your point, maybe I should be more explicit about it, but I think it has taken longer, but I think it's a more fuller project, because I think we've kind of thought through lots of things. I hope anyway. We shall see. The proof will be in the ovens shortly. Okay. Any other questions that anyone had? Steve, yeah.
Thanks. I really enjoyed all three presentations. Mine's a really simplistic question. It's that standard evaluation question for what does success look like?
Yeah, we've talked about this a lot, what success looks like. For me, success would be nurses saying what they're doing explicitly, nurses actually saying what it is, what they're doing, because we're not good at it. We kind of, we don't have language to what we're doing. We just do our thing. A great writer who other nurses in the room might know talked about the behind the curtain, because a lot of the stuff happens that's sort of hidden, and we don't kind of articulate very well what it is we're doing. And in big team meetings, often it's not the nurses that do the talking, it's everyone else, because we kind of don't have a language behind what we're doing. We just know ourselves what works, and nurses are very intuitive. So what success would look like is that we're all calling something the same thing, and we're all saying, hey, we tried this, it didn't work because of these reasons. Let's go for more of these techniques. And then we can all kind of be on the same page and work together with our patient population. So for us, it's about a shared language. That would be phenomenal success. And then building on that so that we can we can help our clients to, the success for us is that they discharge, that they self-manage, that we have no role left. That's the success for us. So it's kind of helping get to that in a better way, I guess. Hope that answers your question.
Going up with all three of those.
Oh, okay, good, great.
Possible.
It'd be more funding for implementation. But then also knowing what to look for in the implementation now. So having specific initiatives based on, I guess, an avoidance or aversion to help seeking and taking that very seriously. But I want a lot of money to be able to implement.
Alicia, would you like to say what this conference have to say?
Yes, can you repeat the question, please?
What sort of success look like for you in your project?
What's the what?
Sorry, what would success look like for you in your project?
What this?
This one.
Oh yeah, I'm sorry. I
Sorry,
just.
Sorry, that it might be the microphone. What would success look like for you in your project?
Oh, sorry. Yes, the success look like exactly. So yeah, so far the success will be to really have the link between to understand the overall picture of interprofessional collaboration, and the success will be that really affords maybe I don't know, like propose a theory beyond that, and to really emerge all these power dynamics, for example, professional stereotypes, all of these factors, to really maybe to say, okay, in the healthcare professional, that actually occur when we discuss, and how do we overcome all these factors, and how would we optimize our team decision making. And most importantly, I would say that it maybe at the end it will be to really make the patient in the middle of this team decision making, even if it's not there, because now we involve a lot of the patient in the team decision making. But even if it's not possible, how we can make the patient appear in this collaboration.
Thanks, Alicia. Anyone else with a question? Sure, who got?
Well, mine's my question, but I think the person. Mine's more common.
So I suppose it's a comment, and that could be a question. I'm hoping not pressurized. So from what I gathered from what you were saying, that there were two sites that kind of fed into the development of the set of coaching techniques, and those two sites
both had brain injuries, so that was the focus. But then there were other sites that like had spinal injury was their focus. So I suppose there is a question about, well, would the coaching techniques be different? And what came to mind was with Archer's modes of reflexivity, that there, you would come across more fractured reflexives and reflexive capacity where there was brain injury. So that must impact the ability or the level of reflexivity with the people that you're engaged with in those settings. So I suppose it's just, do the coaching techniques change when there's that kind of thing going on? And is there a potential to look at the reflexive abilities of the service users within the whole project?
Yeah, thank you for that question. One of the things I didn't get to that we, so first of all, just to be clear, in the first phase, when we were developing the techniques, that was with the 2 brain injury units. And so, yes, the techniques have been developed in those units. And then what we've done is done examples of how these might be used. So we've used documentation examples that we've kind of gathered from the interview data of people that have actually said that, so that we could align it with what the technique was. So nurses themselves can kind of say, oh yeah, I do that. Yeah, now I know it fits under that one. And so the plan is that when we go on to the second rollout with spinal older person's health in general and the private setting, that we will gather those techniques and slide the examples and slide them under the techniques so they make sense for their context. That said, when we looked at the patient factors, which is, I didn't have time to present, but we're really talking about people that are emerging conscious, to people that are, you know, walking and very, very confused, to people that have, you know, regaining their cognition. So it's a really broad level of cognition. And but the same technique can be used, it just can be used in a different way all the long. You just use it slightly differently when people's cognition is emerging. So it could be, if I could quickly say, one of the techniques is provide choice. And so provide choices, I might hold up 2 shirts from the wardrobe and say, which shirt do you want to wear, the red one or the blue one? And you can just point at one, right? So that's a very kind of low cognitive level, just a choice of 2 things. To giving someone choice about what they want to do today, or, you know, some choice about the meal that they want to prepare and what should we put on the menu, you know, like some really high complex providing choice. So it's the same technique, but actually you use it in a slightly different way. And with a spinal person, of course, you know, you kind of just adapt it to that. So we've tried to make them adaptable, I think. I hope that's answered your question. Not sure what time we're to finish, is it? Have we? At 5. Okay. So we still got time for some more questions. Oh, you have one, okay? Yeah.
But sorry, I have a question. Yeah, I just want to add more expression of gratitude. So I think working in health system planning and policy from each of the presentations, all of you did excellent work. There were things in the findings that I can take away thinking about in practice and policy in Canada that are relevant and that are just very helpful and meaningful. And I think it comes from the work that you've done in applying critical realism. And then the other piece is, as someone applying critical realism, just in the knowledge translation, how you presented it, how you know, take complex theories and made it simple, but didn't water it down. I think are really meaningful for how we then take that information back to providers in the healthcare setting, policy and decision makers as well. And so just, yeah, kudos to all 3 of you. It's really, really great work.
Sounds like a beautiful ending, but Heather's got her hand up.
It's just magnificent work. It's so applied and it's so practical, and we were sitting there saying how clear everything was that was presented. And I wondered what attracted each one of you to critical realism when you first started. It's not necessarily the most accessible immediate choice, but it's obviously helped
really crystallize your work and your findings. So how did you come to it? What was the attraction?
For me, I think it's the causality element. So just a constant conjunction just doesn't make much sense to me. Or A leads to B just never really sat well. Or A then B. I just think the world's too complicated for that. And critical realism, I guess that was my way in. So it was cause really. And then looking at the ontology around that and emergence. And the more I saw, the more I like kind of aligned with it. And then you're like, oh, I like believe this now. I like have to use it. So, but yeah, for me, it's the way that cause is described in like an ontologically realist way, which I find very appealing.
Alicia, would you like to respond?
Yes, thank you for the question. So I think my background as a nurse, I work in a surgery setting. And also I was involved for 2 years in research team in cardiology, and really like to have this, for example, my colleagues told me that they are not, after the meeting, often they are not 100% okay with the decision or not at all okay with the decision. And to see this unequal also participation, to see some colleagues that cannot raise their voice, and all of that maybe lead me to critical realism, because it really allows to say, okay, there's other reality that exists. It's not the outcome that we only see. And also one of the things I also read a lot regarding the cooperation process among humans, what's really makes us to cooperate, what permits the condition to have an effective cooperation among us. And actually cooperation is one of the key to foundation of team effectiveness. So it's really the core of the beginning of the thesis, which lead me to choose the critical realism.
Thank you. They were beautiful answers. I wish I had gone first now. I would say all of the areas that we've talked about, and especially working in healthcare, generalization never sat very well with me. Like if 5 out of 8 of my patients experience good health, then that's a problem for me, because what are we doing with the other 3? And so I think it was that for me, just not kind of just generalizing and saying, well, it works with 70% of the population, let's just go with. And because I work in with people with brain injury, it's such a minority, do you know what I mean? And there's a lot of complexity, and you have to think about a lot of things. And so I think it just aligned so beautifully well. I spent a long time looking around and took a little hiatus in my doctoral journey to really kind of figure out how I would underpin things. And I wanted to find something that kind of worked with my, how I believe what I think. And so that's when it was useful for me, I think. Thank you for that question, Kath. I think we're almost at time, are we? Should we call it the end of day 1? Thank you, everyone. A special thanks to my 2 new buddies, Alicia and Reese. Thank you for your presentations. We'll see you all tomorrow.
See you tomorrow. Bye.
Yeah.